please do look out for this conference a bit later on. So without further ado, my great privilege to hand over the session to Professor Amato.
Hello, good morning to everybody. It's 9:30 p.m. here in Sao Paulo. It's my privilege to participate in this meeting. I have had a very many countries in Asia for the last years. And this year, obviously, the last year, we could not make it, but it's always a pleasure to be in contact with this part of the world. The topic, let me share the screen first with you. Just 1 second. I hope you can see my screen now.
Yes, Doctor.
And okay, and then the title for this presentation is something that for me it's an everyday thought, taking care of patients. And precisely this afternoon we have to discuss very deeply this topic in my ICU. So what COVID patients have taught us about lung protective strategies, and which is the right moment to relax lung protection. So the question is, should we tighten or should we relax lung protection? So in 2015, now 5 years ago, we developed this concept of driving pressure, which is a variable that you can calculate easily on the ventilator and requires controlled mechanical ventilation. And then we showed in more than 3,000 patients that this is the strongest predictor of survival. And not only this, driving pressure was the mediator of death in those patients, meaning that if I put together all the trials on lung protective strategies, including high PEEP trials, low tidal volume trials, driving pressure in all these trials emerges as the most important variable linked to survival of those patients. And this was already confirmed by many different papers about ECMO, papers on protective strategies in Europe, and in animal studies also we can clearly demonstrate that much more important than controlling tidal volume or plateau pressures, the control of driving pressure is looks like to be the most important parameter to control at the bedside. And let's say the intuition about the importance of this parameter can be explained by these mental experiments. You have to imagine that you have two patients, one patient with almost normal compliance of the respiratory system, and another patient with severe lung injury. So you can see that most of the lung was atelectatic in this patient with a remaining medium lobe open. And the chest wall compliance for both patients is exactly the same. So this is a normal value for the chest wall compliance. But this patient has a 50 of compliance of the respiratory system, and this patient has 10. And these two patients, they arrive at your ICU at night. And then the patients are approximately of the same size, and you're going to apply 6 mL per kilogram in both patients, which means 400 mL in these two patients. And then when applying this value in this patient on the left, I can calculate the transpulmonary pressure. You can easily calculate using conventional formulas that you can find in any physiology book. We don't have to go into the details, but you can easily calculate, knowing this compliance of the chest wall and the compliance that you can measure on the ventilator, that the transpulmonary pressure of this patient is going to be 4, but the transpulmonary pressure of in this patient is going to be 36. So it's a big difference, big. You can see it's 10 times difference. But at the bedside, you just measure, okay, this patient has a little bit lower compliance, and then physicians typically, they don't realize the impact of the compliance of the patient. But here, the transpulmonary pressure is going to be 36. And if you take any old study, any classical study about ventilator-induced lung injury, this parameter, this number, is enough to cause alveolar edema, permeability alterations, interstitial air. You have injury of the whole vascular system, alterations in permeability. So this is a disaster. Typically, any animal species that you can think about, horse, dog, cat, and especially human beings, they are going to be almost dead after 4 hours of ventilation in this parameter. So tidal volume, is it important? You can see that I have exactly the same tidal volume here, conventional 6 mL per kilogram. And how can I think that tidal volume is the, let's say, the ultimate variable to control at the bedside? It's absolutely, let's say, nuts. It's impossible to think that this parameter could be the most important one. So you certainly have to scale your tidal volume to the lung size, because this patient has a big lung size and this patient has a very small lung size. One of the best parameters to measure lung size is compliance, because compliance is proportional to lung size. This is very well demonstrated in any physiological study. How you calculate compliance? Compliance is tidal volume divided by driving pressure, plateau pressure minus peak. So if you do the mathematical cancellation, development this, so you cancel tidal volume, then you come out with driving pressure. So driving pressure is a normalized tidal volume. It's precisely tidal volume divided by compliance. So you can easily calculate now that if I put the same tidal volume for 100 mL, my driving pressure is going to be 8. And in contrast, my driving pressure is going to be 40, which typically is associated with 4 times higher mortality in a patient with ARDS. Exactly the same tidal volume, 6 mL per kilogram, is causing completely different consequences. So this mental experiment explains in my mind why, as clinicians, we should not pay attention to 6 mL per kilogram. You should pay attention to driving pressure. And it's absolutely true that during controlled mechanical ventilation, if transpulmonary pressure increases, your driving pressure always increases. So if you're doing controlled mechanical ventilation, driving pressure is a big surrogate of the transpulmonary driving pressure, which is the very precise mediator of injury in all animal experience. Transpulmonary pressure is difficult to measure at the bedside, but driving pressure is very easy and is the best surrogate that you can use at the bedside to predict the possibility of ventilator-induced lung injury. In the last month, we published this paper in the Blue Journal, American Journal of Respiratory and Critical Care Medicine, in which we are precisely stressing the importance of lowering tidal volume in patients with very high elastance, or precisely the patients with very low compliance. just as a remark, how important is to track driving pressure instead of tidal volume. Let me give you some, let's say, some hints of this publication and some figures of this paper. So we took 1,000 patients enrolled in trials on low and high tidal volume. You can see here that this is the low tidal volume arm, and this is the high tidal volume arm. And in the x-axis, you have here elastance, which is the inverse of compliance. So these are the patients with good compliance on the left, and patients with bad and very low compliance on the right. As you can see, because let's say the target for these patients at the bedside was to use 6 mL per kilogram, the average is 6, but clinicians at the bedside, they apply a little bit less than 6 in patients with low compliance and a little bit more than 6 in patients with good compliance. And the same when they are using high tidal volumes. Okay, this is 12, but then when the patient has a very low compliance, they tend to decrease a little bit. But in general, there is a big difference in tidal volume between these two arms. But when you look at the driving pressure, you see a big difference in driving pressure, especially in those patients with very low compliance. So this paper is a little bit obvious, but it's just stressing a very important point. Which are the patients in which you should be very restrictive with tidal volume? It's precisely those ones, the ones with very low compliance, because any increment in tidal volume is going to cause a big increment in driving pressure. And as a result, we are showing here what happened with the mortality of these patients. So risk of death at day 60. So this is almost 1,000 patients, and you have 200 patients in each quintile of elastance or compliance here. And then you can see that whatever the tidal volume, the consequences are not remarkable when you have good compliance. But when compliance is very low, using a lower tidal volume makes the whole difference in terms of mortality. And this is exactly what you should have in mind, that if you have a patient with low compliance, this is the patient in which you should be very restrictive with tidal volume. And vice versa, if the patient has a little bit better compliance, you can relax a little bit on your tidal volume control. Another important point for this talk. This is a CT of a patient with ARDS before he got ARDS, 1 month after ARDS and 6 months later. So obviously this patient survived. As you can see, you have very intense lung fibrosis, which is still present 6 months later, okay? There was some recovery of the reabsorption of the fibrosis. This is a little bit in contrast with the old concept that if you have lung fibrosis, you are dead. This is not true. There is some reabsorption of fibrosis in patients with ARDS. And, but the most striking finding of this paper, which I strongly advise you to read this paper that we published a few years ago, is that there was a remarkable relationship between vital capacity 6 months later and the driving pressure that you used as an average during the first week of mechanical ventilation. And this relationship is inverse, which means that the higher the driving pressure you are applying the ventilator, the lower is going to be the vital capacity 6 months later. And this relationship cannot be found with tidal volume or with compliance, which means that whatever the compliance, whatever the tidal volume that you use, there is no relationship with vital capacity, except that driving pressure is very strongly related to this variable. And then, much more than this, when we measure procollagen production in this patient, procollagen 1 and procollagen 3, and this is the first week of mechanical ventilation, when the driving pressure was below 13, there is no increase in this mediator in the bloodstream. But if the driving pressure was high, then you have a progression of procollagen in the blood, which means that this patient is increasing the collagen production in the lung. And if you look at mean lung density that you find in the CT 6 months later, if your driving pressure is high, you have a higher lung density, which means that this patient has sequela on the CT and more collagen in the lung 6 months later. So this is a very interesting finding, because now there is many studies on lung fibrosis, especially idiopathic lung fibrosis, linking the driving pressure during daily ventilation, during spontaneous ventilation, and lung fibrosis. And this is the same is true for ARDS, because lung fibrosis is the consequence of lung inflammation, and driving pressure is the mediator of lung inflammation. And just to show you an example in our ICU, this is a patient that was planned to receive open lung biopsy in the median lobe here. And then this patient was submitted to open lung biopsy with thoracoscopy. And this is the lung that has to be ventilated during anesthesia, the left lung, and the pleural space of the right lung was open, and then we took a chunk of this lung. And this is the scar of the right lung biopsy. But pay attention to what happened in the left lung after 2 hours of anesthesia, just 2 hours of mechanical ventilation in a patient with lung fibrosis. How they did the mechanical ventilation during anesthesia. So what they did is that they applied a tidal volume of 6 mL per kilogram, a plateau pressure of 29, and a PEEP of 0. This looks an innocent mechanical ventilation with 6 mL per kilogram, so apparently a protective mechanical ventilation, low plateau pressure below 30, but what the anesthesiology missed, or the anesthesiologist that he missed, is that the driving pressure was 29, and 29 increases mortality by 4 times already, if we believe in the paper published in the Blue Journal. So just 2 hours of anesthesia with 29 of driving pressure in this left lung increased the lung inflammation and fibrosis, ground glass opacities, and this patient ultimately died. What happens during spontaneous effort? So do we have evidence that driving pressure is also important during spontaneous efforts? So some years ago, Brian Kavanagh developed this concept in which he was proposing the concept that positive pressure ventilation is a little bit more dangerous than negative pressure ventilation. For instance, if you apply a negative pressure surrounding the thorax, imitating the movement let's say, caused by the respiratory muscles. And he made this hypothesis that, okay, negative pressure is a little bit better because it's a little bit more natural, but this was absolutely false. And Brian Kavanagh, before dying, he treated himself, and he told us that, okay, this was absolutely wrong. In fact, negative pressure ventilation is as bad as positive pressure ventilation. And this is very important because this is the main concept developed for the seminal studies on ventilator-induced lung injury many years ago by Didier Dreyfus. So in 1988, he published this seminal paper showing that when you apply high tidal volumes and high driving pressure, you increase permeability of the lung and you increase the edema of the lung. This is the normal level. This dotted line is the normal level. So you are well above the normal levels. But if you apply negative pressure ventilation, imitating your inspiratory muscles, so, and having approximately the same tidal volume, you have the same degree of lung injury, if not more. And the explanation for this higher degree of lung edema is related to the increased venous return and the increased transcapillary pressure that you have during negative pressure ventilation. So in fact, if you have exactly the same tidal volume during positive pressure ventilation or negative pressure ventilation can be even worse. So this is very important to think at the bedside. So in my mind, the two strategies are creating exactly the same driving pressure. The only difference is the pleural pressure, that in this case is positive and in this case is negative. But the total driving pressure applied across the respiratory system is exactly the same. So if we are using spontaneous ventilation or pressure support ventilation, which is the most common mode during spontaneous ventilation, you should think that your total driving pressure is always the sum of the driving pressure generated by the ventilator and the driving pressure generated by your inspiratory muscles. So in fact, you have to sum up both components to have a clue what is happening to your patient. And to understand how much pressure you have in total, you can always do this calculation that is very easy to perform at the bedside. You take your tidal volume, you divide by compliance, and then you know this total sum, okay? So you can always divide tidal volume divided by compliance, and you can understand how much driving pressure you are applying in the total respiratory system. Let's take an example. I have a patient with pressure support of 8, tidal volume of 360, so looks like an innocent mechanical ventilation and very, let's say, safe mechanical ventilation, except that this patient, a few hours later, so few hours before, was receiving controlled mechanical ventilation, and then we could calculate his compliance, which was 12. So now I have 360 mLs of tidal volume divided by 12, and I can understand that my driving pressure is 30, which is a very high number. If you look at this graph, look the mortality of these patients. It's twice the average and 4 times the mortality of these patients that are under the most protective mechanical ventilation. So this patient has approximately 80% mortality under mechanical ventilation, even using a kind of innocent pressure support ventilation with 8 centimeters of water. So very important concept to keep in mind. Okay. So one of the most difficult parts, let's suppose that you don't want to paralyze the patient, so you don't know the compliance of this patient. What else you can do at the bedside to estimate the total driving pressure? Okay, number 1, you give a bolus of propofol. You have the ventilatory drive of the patient calm down. You have controlled mechanical ventilation, and then you are measuring compliance. So remember, you can always calculate your driving pressure by dividing the tidal volume that you measure during pressure support divided by the compliance that you measure a few minutes before. Compliance does not change from 1 minute to the next. It's a property that representing the situation of the lung parenchyma, and typically it changes very slowly, about 10% after 24 hours or 48 hours in a very slow pace. So if you're applying the same PEEP level, your compliance is approximately the same a few hours before or a few hours later. So you can always measure compliance daily and apply this formula. But we are going to discuss these two methodologies to estimate the driving pressure applied in a patient, which consists in an inspiratory pause applied during pressure support ventilation or proportional assisted ventilation or whatever the mode, or an expiratory pause that can be applied also in whatever the mode of mechanical ventilation. And keep in mind that the inspiratory pause is a useful maneuver also to measure the muscle driving pressure. And the expiratory pause can also be very useful to measure the muscle driving pressure, with the additional advantage that the expiratory pause is going to reflect the inspiratory and expiratory muscles together. Looks like a little bit complicated, but I'm going to explain you and in a very easy fashion. Oh, okay. So this is a ventilator tracing. I'm going to stop here. So this is a typical pressure support ventilation, right? This is the flow wave curve. This is a pressure support followed by an inspiratory pause. You can see that the patient, instead of having a decrease in airway pressure, you see an increase in airway pressures. The patient has some inspiratory effort and relaxed it again, and I come back to the same level. So pressure support, inspiratory pause, patient effort, and inspiratory pause again, okay? So I ask you to read this paper published by Giacomo Bellani, where he's describing this method of measuring the inspiratory pause during pressure support ventilation. So in this paper, he's showing us that in this particular patient receiving pressure control ventilation, he applied an inspiratory pause, and then he had the most common decrease in plateau pressure, as you should expect. So because now you don't have resistive pressures caused by inspiratory flow, and then your plateau pressure is slightly below your peak airway pressure. However, when you apply pressure support and the patient is doing some strong effort, now you have a situation that it's a little bit different. Because now, when you apply the plateau pressure, your plateau pressure inspiratory pause is above the pressure support level, as we have seen in the previous slide. Why this? Because the tidal volume during pressure control ventilation, passive, patient is not performing any effort, has a tidal volume of 400 mL. But now, because I have another driving pressure applied in the system, so now I have a combination of muscle plus ventilator, then my tidal volume increases a little bit because the patient is pulling some air from the ventilator. And then when the patient relaxes, I have an extra tidal volume inside his lung and chest wall. And this extra tidal volume that I can measure here is going to cause an increased elastic pressure in the lung that is going to be reflected here. As a result, my airway pressure now during an inspiratory pause is going to be above the pressure support level because all this volume of air is inside the lung, increasing the elastic recoil pressure inside the chest. And this extra pressure is called PMI, inspiratory muscle pressure, okay? Caused by this extra tidal volume promoted by the inspiratory muscles. You can also call this the muscle driving pressure promoted by the patient. In some cases, when you measure at the bedside, you get very surprised. Because you cannot believe that the patient is doing such an amount of effort. Like in this patient. The pressure support level was at 20 centimeters of water measured at this point. But when we performed an inspiratory pause, so zero flow, sustained volume inside the chest, look, my airway pressure, 37. And 37 here during relaxed conditions, because you activated the Herring-Brauer reflex, and typically the patient relaxed during this inspiratory pause, which means that this is precisely equivalent to having a plateau pressure of 37, that you never do it, you never allow it during controlled mechanical ventilation. Okay, so 37. So which means that the muscle driving pressure is 37 minus 20, 70. And the total driving pressure applied in this patient is the subtraction of 37 minus PEEP. 37 minus 14, which is 23, so a very high driving pressure. So this maneuver is very useful at the bedside, because you may think that this patient has an innocent pressure support ventilation with just a 20 of inspiratory pressure, but in reality, if you are not applying the inspiratory pause, this pressure is going to be hidden, and you don't understand that this patient, in fact, is receiving a very high effective driving pressure. So again, whenever you are doing pressure support ventilation, you can always estimate your total driving pressure by knowing compliance. If you don't want to paralyze or give sedation to the patient, you can still apply an inspiratory pause, as I have just shown. And then by using this inspiratory pause, you can calculate the inspiratory muscle activity, and you can also calculate the total driving pressure applied into the system. Okay. But very recently, just 1 or 2 years ago, we have a further development of these maneuvers. And then we have two other authors, Bertoni and Golliger, that in 2019, they published another very interesting paper. And this paper is talking about the expiratory pause maneuver. So again, I have here airway pressure tracings, pressure support ventilation, very low level of pressure support. But then instead of applying an inspiratory pause, I applied an expiratory pause, which means that when the patient has just triggered the ventilation, the ventilator occludes both inspiratory and expiratory limb of the ventilator. So this is an unoccluded breath. And if I have an esophageal balloon, I can realize that this patient is doing a negative pleural pressure, triggering a pressure support ventilation. And then during the expiratory pause button application, I see that the drop in pleural pressure is 100% reflected by a drop in airway pressure. Why? Because there is no inspiratory flow, so there is no dissipation of the force applied into the system to generate any elastic pressure, which means that the total force performed by the inspiratory muscles is going to be reflected in the drop in airway pressure, because there is no flow generated. And then in this condition, so you can measure this occlusion pressure as a surrogate of your pleural pressure swing, because there is no variation in transpulmonary pressure, because there is no generated tidal volume or inspiratory flow. So the nice thing about this paper is that they have shown in this paper that when you compare your muscle pressure during unoccluded breaths and your muscle pressure generated during an occluded breath, there is a slight difference, and this is a little bit higher than this, but in a very predictable way. So your muscle pressure in those unoccluded breaths is 75% of what you measure here. So it's very easy. You perform this maneuver, let's say you measure that your occlusion pressure is 12. So your muscle pressure is going to be 9. Okay, so very easy. And the nice thing about this maneuver is that in some few patients, it gives you a complementary information on top of the inspiratory pause maneuver. So typically, I like to apply both maneuvers in a patient. So for instance, this is a patient under pressure support ventilation. So then I applied an inspiratory pause. And then I don't see neither an increase in airway pressure nor a decrease. So looks like that the plateau pressure during an inspiratory pause is exactly at the same level of the pressure support. Okay, but then we applied an expiratory pause maneuver. And then I see this big drop. Wow, this is a little bit awkward. So how come that I don't have any PMI, any muscle pressure measure here, because my plateau pressure is exactly at the pressure support level. But when I applied an expiratory pause, I see this big drop in airway pressure. And if I take 75%, I can understand that my muscle pressure is 9. So why I could not measure any inspiratory muscle activity here, but I could measure this big drop in airway pressure. From where this force came from? And then there is a very interesting explanation nowadays telling us that this can only mean that you are using your expiratory muscle to promote some tidal volume. So you have to keep in mind that your tidal volume is generated by the ventilator, the inspiratory muscles, but also by the expiratory muscles. And this looks like a little bit complicated, but it's not. Think about this. This is the tidal volume of a patient during assisted pressure control ventilation. This is time, okay? And then this is the tidal volume measured by the ventilator, and then this patient had received some paralytic agent. So we applied a bolus of succinylcholine, okay? So paralysis started right here. Okay, but this is the signal that I can collect from the EIT. So EIT can give you a plethysmogram, which is a surrogate of the variations in volume of the chest, okay, inside the chest. But the nice thing about EIT is that I can track the absolute changes in lung volume. And then when I see the same sequence of events, I can see that the tidal volume decreased because I had a decrease in both. I had a decrease in inspiratory volume, but I also had an increase in end expiratory lung volumes, what we can call as FRC, functional residual capacity during mechanical ventilation. So this drop in tidal volume was caused by the, let's say, the paralysis of the inspiratory muscles, but also paralysis of the expiratory muscles, because it means that this patient was actively, let's say, making an effort to go below FRC during every expiration. And this is very clear when you measure intra-abdominal pressure or esophageal pressure. You can see that after paralysis, abdominal pressure decreased, and this patient stopped of doing some expiratory force to exhale some tidal volume. And then why patients, they activate the expiratory muscles during mechanical ventilation? Is because they have dyspnea and they have the same problem that they have when they are doing effort. If you are running, all of us, we achieve, let's say, 2 liters of tidal volume during a marathon because we use, let's say, half of this tidal volume is generated by your inspiratory muscles, but half of this tidal volume is generated by your expiratory muscles that they When they go below to FRC, they gain some potential energy from the rib cage, and then they generate a higher tidal volume during the next inspiration. So you cannot neglect the activity of the expiratory muscles during mechanical ventilation. And then this can be captured by the expiratory pulse, and then you are capturing the total force performed by the respiratory muscles to generate some extra tidal volume. Okay, so two important concepts we have discussed in this presentation. The first one is that driving pressure is not only causing inflammation, it's causing lung fibrosis. The second concept is that driving pressure, you have to include in the computation of your driving pressure the action of your respiratory muscles. But you have always to remember that your respiratory muscles, they are composed by the inspiratory muscles, but also by the expiratory muscles, okay? But let's take some brief look in the evidence we have in the literature on the action of the respiratory muscles and the promotion of lung injury. I invite you to read this paper that was published by our group in combination with some very nice researchers from Japan. And in this paper, we are showing that whenever we apply spontaneous breaths on top of pressure control ventilation, and this generates an extra driving pressure, you promote lung injury in rabbits, pigs, and humans. And in pigs, we could show also that you have a very clear signal of lung inflammation when the animal is doing a very strong effort, even if the animal is just receiving 6 mL per kilogram of tidal volume. So in the PET scan, shown in yellow colors, you can see the signal of lung inflammation and the location of lung inflammation when you have strong diaphragmatic contraction in a previously injured lung. And we can see that this action of the inspiratory muscles causes a big inflammation, especially in the peri-diaphragmatic regions, dorsal regions and the regions very close to the diaphragm. Other groups also have shown this, and interesting enough, when you apply a little bit higher PEEP, which counterbalances the action of the inspiratory muscles, you can decrease lung inflammation. So we can decrease lung inflammation by giving a little bit of paralysis or by increasing PEEP in these animals. So again, you have always to think that your total driving pressure is the sum of what you set on the ventilator plus the action of your inspiratory muscles. Just to show some old experiments from Takeshi Yoshida, published in the Critical Care Medicine a few years ago, almost a decade ago. He was showing in rabbits with lung edema, and these animals were under controlled pressure-controlled ventilation with paralysis. So lung edema in green. Then the animals started to breathe a little bit on top of pressure control. So we have assisted pressure control ventilation. Tidal volume increased a little bit from 5 mL per kilogram to 7 mL per kilogram, as it happens to our patients when they are awakening from the sedation. A slight increase in tidal volume. Initially, oxygenation improved, the animals looked better, the CT got a little bit of recruitment, PO2 increased, but a few hours later, boom, big catastrophe. Because now you have applied a very high driving pressure for 6 hours, and these animals have a huge lung edema. So Takeshi published 2 papers showing the same story, and you have to take care of your driving pressure during pressure support ventilation or assisted pressure control ventilation. Very important. And finally, I would like to stress something that I have observed in many ICUs around the world. Why? And this is, let's say, a kind of, let's say, observation that I collected along these years. My observation visiting many different ICUs around the world is that the total driving pressure during spontaneous ventilation is often underestimated. And typically when physicians are applying pressure support ventilation, they believe that everything is already gone. So the problem of ventilator-induced lung injury is gone. And why this is happening, and then why physicians are not paying attention to the total driving pressure. I think one of the reasons is a kind of religion that physicians believe that spontaneous is always better than mechanical. I hope I have showed you that this is not true if you look at the literature. So spontaneous effort can be as bad as, let's say, an effort promoted by the ventilator or a driving pressure promoted by the ventilator. The second reason is that physicians very often they misunderstand and they think that the set level of pressure support is equal to driving pressure, but this is absolutely fake. It's false during pressure support ventilation. Typically, your driving pressure is well above your set pressure support level. And then we have also discussed that when you have expiratory effort, you can increase the potential energy for the next cycle. You can increase your tidal volume, and this is another source of increased driving pressure. We don't have time here to discuss the Pendeluft, but this is a subject for a next conference. Keep this in mind. So pressure support is not equal to driving pressure. Driving pressure is always above your set level of pressure support during assisted mechanical ventilation. And I like to keep this image in mind that this is the level of pressure support and this is your patient effort, which can be hidden behind a low level of pressure support, like in this maneuver, right? So keep this image in mind. Okay, so what happened in a patient with COVID? What we should do in a patient with COVID? Very recently, in the last year, we published this paper also in the Blue Journal. It's a kind of, it's a paper is the result of many physicians thinking together. I think the main author of this paper is Ewan Golliger. I participated also in this paper. And then the concept that we are trying to develop here is that when you were let's taking care of a patient, especially a patient with COVID, and this is a patient that is going to stay in your ICU for 3 weeks in average. This is the experience around the world. So it's an average of 3 weeks of mechanical ventilation. You have to think in a strategy that is protecting the lung at the same time that you are protecting the diaphragm. So the idea of this paper is that at the same time that you have to keep lung protection, you have to keep some diaphragmatic protection. And then think about a patient with COVID. The patient is going to stay in your ICU for 3 weeks, and it's going to be laying down in a bed for 3 weeks. So you have to think about both organs at the same time, the lung and the respiratory muscles. One of the big problems with the lung is decubitus atelectasis. And decubitus atelectasis, it's something very, very, very important, because think about this. Lots of studies have shown that atelectasis during anesthesia is a big problem. And anesthesia, for instance, an abdominal surgery lasts for 4 hours. But this patient is going to stay for 3 weeks under mechanical ventilation. So decubitus atelectasis is a very prevalent phenomenon. Also, you have to think about these problems that we have discussed, that at the same time that you have to keep lung protection, you have to maintain the trophism of the respiratory muscle. So you have to keep some level of activity of the diaphragm. And how much activity I have to maintain? There are now some good studies suggesting that to keep the trophism of the diaphragm, you just need the normal effort that you do during normal conditions. And how much is this? 5 centimeters of water. So how much muscle driving pressure I generate during a quiet tidal run? 5 centimeters of water. So in my mind, the ideal strategy during mechanical ventilation is to keep at least 5 centimeters of water of muscle driving pressure. Then you keep all the inspiratory muscles working. And at the same time, you try to keep your total driving pressure below 15 centimeters of water. So this would be ideally your strategy. So we should avoid, during the whole mechanical ventilation, a muscle driving pressure in between 5 and 15 centimeters of water, preferentially close to 5. And then if you're applying a muscle pressure close to 15, at least your ventilator driving pressure has to be very low. And how to do this? You have to individualize. And then you have to apply a specific strategy to each patient. So what we have observed and what is the experience around the world about patients with COVID? One of the main experiences collected here by some French investigators is that when you observe what happens with the compliance of the respiratory system of patients with COVID, you see that there is a deterioration of compliance along the weeks. So this is the days of mechanical ventilation, and you can see that compliance is going down along the days that the patient stay under mechanical ventilation. And one of the main reasons, and we have collected data now to prove this, is the decubitus atelectasis, because these patients, very often they develop this kind of atelectasis along the days. They have a little bit of lung fibrosis, but what predominates is decubitus atelectasis because this long stay into the ICU. In some patients, when you apply very high driving pressure, you can have extensive lung fibrosis. But in many patients, you have much more of this. It's a combination of lung fibrosis and decubitus atelectasis. And both, they are decreasing a lot your compliance of the respiratory system. A typical image in the EIT suggesting that you have decubitus atelectasis is this image that you collect in the EIT. If you look at the EIT, you have ventilation only in the ventral part of the lung. So 72% of the tidal volume is going to the ventral part of the thorax, and only a third is going to the dorsal regions. So what we have observed is that in COVID patients, and we are doing a randomized trial on this, and we have collected already data in 50 patients that were randomized. What we have observed is that by using EIT, you can detect a certain level of PEEP that is going to avoid decubitus atelectasis. How much PEEP is this? You can see in this slide that is not much more than what we use in the ARDSNet table, but it's completely different. So in some patients, you have to increase your PEEP level from 5 to 12. In other patients, if you set your PEEP based on the ARDSNet PEEP table at 14, you have to decrease to 8 to have a perfect balance between ventral and dorsal ventilation. And then, because what we should think when we are using EIT is something like this. As you know, when you use EIT, you can titrate PEEP, like in this graph. You can decrease your PEEP level step by step, and then you can calculate how much collapse and how much hyperdistension you have. And you can see collapse in red, hyperdistension in blue. So this crossing point represents a moment or a PEEP level in which I don't have too much collapse and I don't have too much overdistension. And typically, I have equal balance between ventral and dorsal ventilation because this patient doesn't have too much overdistension and not too much dorsal collapse. And so this PEEP level typically gives you a good balance between not too much overdistension, not too much collapse, and 50-50 distribution of ventilation between ventral and dorsal parts. And what we have observed is that the PEEP level to promote this pattern is not too much higher than the low PEEP ARDS-NET table. In general, it's the same, but in some patients it's higher, some patients it's lower. The only problem is that you have to individualize. And what we are testing here, we are testing if some individualization of PEEP is going to help us to treat some patients with COVID. And then how we can more or less predict, let's suppose that you don't have EIT, how you can predict that this patient has a potential to recruit with a little bit higher PEEP without too much overdistension, how to predict that this patient is going to benefit from a little bit higher PEEP at the same time that I can avoid hyperdistension. So we have been looking for an index of recruitability at the bedside, like in this animal. So you can see that this animal, when submitted to different PEEP levels, he can recruit a lot. And then, for instance, when I was applying 5 of PEEP, 15 of PEEP, still a lot of collapse. Then I applied some very high PEEP, I recruited the lung. When I went back to 15 of PEEP, I have an open lung. And then even at 5 of PEEP, I still keep a lot of recruitment and I can have much less collapse on the CT. How can I predict that this patient can benefit from PEEP? And then that in this patient, I could use a little bit higher PEEP than predicted by the ARDS-NET table. There are some tools that we are developing at the bedside. For instance, these two we are developing together with this ventilator. And then it's an automatic tool that you can apply at the bedside. And just to give you some very brief information. So what we do with these two is that you are increasing your PEEP level step by step, like suggested here. These two can do this maneuver automatically for you. And then you apply this incremental and decremental PEEP trial. You can set your safe boundaries and you are just measuring the compliance, the behavior of compliance. So in this particular patient, compliance decreased a little bit and then increased a lot when we were decreasing our PEEP levels. And we have shown that whenever this happened, this patient is a potential patient that can be benefited from PEEP. And we have done some studies proving that this is true using CT or EIT. For instance, in this particular patient, when we applied a little bit higher PEEP and came back to a PEEP of 15, there was a 100% increment in the compliance of this patient. And in this other patient, there is no benefit of applying a higher PEEP. And you can see that whatever your PEEP level, your compliance just goes down, goes down, goes down when you are increasing or decreasing your PEEP level. So in this particular patient, there is no benefit in titrating PEEP. And then, when you have this benefit and the patient is very recruitable, like the patient I was just suggesting, so you can clearly see the EIT that the patient has very ventral ventilation, and then after applying the proper PEEP, boom, you can have a very more homogeneous ventilation. You have an equal distribution between ventral and dorsal ventilation, and this patient has a much lower driving pressure. So let me now summarize what we are doing at the bedside with these COVID patients. First, we are trying to keep lung protection. And how you keep lung protection during the controlled phase of mechanical ventilation? You have to find the lowest possible driving pressure. And which is the best strategy to do this? To minimize as much as you can your tidal volume and to apply the proper PEEP that gives you a balanced distribution of ventilation. And by doing this, you are always minimizing your driving pressure for that tidal volume. Okay, but then the patient needs some assisted mechanical ventilation, and you have to keep the trophism of the respiratory muscles. What you have to do? You have to do the transition from the controlled to the assisted mechanical ventilation, keeping your total driving pressure under control, but keeping your muscle driving pressure within these boundaries to keep the trophism and to keep the condition of your inspiratory muscles. And to do this, obviously, you have to individualize your strategy. It's almost impossible to do this with, let's say, a cookbook. When you are entering the assisted phase of mechanical ventilation, it's always a little bit, it's a challenge to keep your inspiratory muscles under control, because we have seen that in these patients with COVID, they typically awake, when they get away from the sedation, they get awake with a very high ventilatory drive. So what you can do at this moment to control the muscle driving pressure? First of all, I'm telling you here that you have to keep in mind that the important parameter is the total sum. So if your patient is doing a higher muscle effort, at least you should minimize your ventilator driving pressure. So please reduce your pressure support level. It's very important to think that a low pH is always going to enhance your ventilatory drive and enhance the P.1 and the ventilatory drive, so the patient is going to perform a stronger effort. So as much as you can, you should promote some alkalosis, metabolic alkalosis, to counterbalance your hypercapnia if needed. Also, in third, you can always apply a little bit higher PEEP to do two things: to decrease the ventilator driving pressure and also to rectify the diaphragmatic curvature. And by doing this, you typically decrease a little bit your occlusion pressure, your inspiratory muscle pressure. Something that we have learned in the last years is that the control of the PO2 can also influence the ventilatory drive. So keeping the PO2 very close to 55 or 60 can enhance the ventilatory drive caused by hypercapnia. So you have to keep in mind that a little bit higher PO2 sometimes attenuate the ventilatory drive of the patient. And finally, among all the drugs, propofol is the one that can decrease the muscle effort the most, much more than opioids, okay? And you can always paralyze the patient again. So sedatives are very different. You have to keep this in mind. Opioids are not good to decrease the ventilatory drive. Okay, now my last slides, just to show you two slides. By applying this general strategy in which we try to keep the total driving pressure under control during the whole stay of the patient, we have done this randomized trial and we are collecting the results right now. And we are going to have we are we are having right now an interim analysis with the first 50 patients. And what we have observed, and these 50 patients are, all these patients, they are COVID patients, very severe COVID patients, which enter the ICU typically with a PF ratio below 150 and very low compliance. So in one arm, we are applying the conventional ARDSNet strategy low PEEP table. In the other arm, we are keeping this strategy in which we individualize the PEEP level. It's not necessarily higher PEEP than in this arm, it's just the PEEP level that is keeping the lowest possible driving pressure. And then we apply this sequence of maneuvers to keep the total driving pressure under control. What happened with these first 50 patients? So when we observe the behavior of compliance during the first 3 days, we can see that in contrast with the progressive drop of compliance during the ARDSNet strategy, this extra protection is increasing progressively our compliance along the days because we are avoiding decubitus atelectasis and we are avoiding a too high driving pressure. I like very much this graph of compliance because it's telling us, it's suggesting us that we are changing a little bit the injury in the parenchyma because compliance, it's not a property of the lung that changes from 1 minute to the next. This is really meaning that very likely these patients are improving the lung condition along the days. And this was one of the first signals. This slide has more than 30 years when we started to apply protective mechanical ventilation in patients. And one of the first signals that the strategy was promoting some lung protection is the improvement of compliance along the week. And secondly, we are measuring now how much time we need from randomization to the point that the patient doesn't need any oxygen to breathe. So it includes the weaning time and also how much time this patient is breathing with supplemental oxygen. And as you can see, when we are applying this strategy, we can increase the percentage of the patients that don't need further oxygen to breathe along the days. And this was the preliminary analysis with a few patients. And then nowadays, this is the current situation of this trial. Obviously, these results are very preliminary. I cannot tell you that we have, let's say, all the answers for this moment. But for us, it's this trial, it's a kind of a continuation. It's a demonstration, at least, that we can collect some physiological benefit on these patients if we apply this strategy that is protecting the lung and the diaphragm at the same time. This is still very preliminary, but I would like to share this experience with you. We still have to learn a lot with this pandemic, and I think we are still at the very beginning. Thank you very much.
Wow. Thank you very much, Dr. Amato, for that very comprehensive discussion that you have shared with us today. And of course, we would like to thank you for this learning session. There is a lot to learn, really, and a lot to consider with regards to mechanical ventilation. So as Dr. Amato, if you may, we're moving on to the next part of our lecture session. And the floor is now open for any questions from our participants in today. And you may unmute yourself and ask the question, or you may as well type them in the chat box. But really, Dr. Amato, thank you for pointing out a few things, especially the use of driving pressure, the proper use of pressure support ventilation, as well as the proper use of PEEP, the role of sedation and paralysis in many mechanically ventilated patients, and of course, the individualization of management of patients, particularly the proper use of tidal volume and a consideration of the use of high and or low PEEP. So there's, as you mentioned, there's not a one-size-fits-all solution for this, and doing individualization is key. So while waiting for our participants to come up with their questions, perhaps I would like to just jump in and throw at least two questions, Dr. Amato, if you may. Our first question is, should we always titrate mechanical ventilation based on driving pressure?
It depends. In general, my answer would be yes. But I have a general, let's say, philosophy that sometimes the optimum is the enemy of the good, right? And then, so if you're applying a certain pattern of mechanical ventilation and you can easily recognize at the bedside that the total driving pressure in this patient is very low, the patient is comfortable, then I maybe I'm not going to touch in this patient. I'm just going to follow and taking general care of the patient. But whenever I go at the bedside and I see that the patient has a total driving pressure above or approaching 15, and especially when exceeding 15, I always try to optimize, because okay, the titration of PEEP is a little bit, let's say, it's a little bit stressful. You have to challenge your patient, but you are challenging your patient for a few minutes, and then you are collecting the benefit for the next weeks. So I always advise. So my general answer: if you detect that you are close to a dangerous driving pressure or above a dangerous driving pressure, you should always titrate something.
Thank you, sir. Let me just check our chat box for any questions from the audience. But before I do so, I just wanted to thank everyone who attended this session, especially our doctor participants, our respiratory therapists, all the way from Thailand, Indonesia, Singapore, Malaysia, among others. Pardon me if I'm not seeing everyone in the participants list, but thank you really. And again, please help yourself. You can unmute yourself and ask the questions directly. Maybe I can call on Dr. Naplika from Thailand. Dr. Naplika, do you have any question? Or our colleagues as well from the Philippines, our doctors from the Philippines and respiratory therapists. So while waiting for another question, because we talk about COVID-19 management, doctor, I know our topic is about lung protection, but in your practice, what is the role of prone positioning in COVID? Do you use a lot of prone positioning in your country?
A lot. I think this is something this was a very interesting insight. I think COVID patients, they gave us, because of this long stay. I have had patients in which, let's say, I had to do prone positioning for 10 days, for 15 days. And I can guarantee you, because now we in our ICU now we have 10 beds and we are using EIT in all the beds, and then all the patients that are monitored by EIT, and when we prone, we keep the monitoring, and then we see why these patients they deteriorate or they keep the benefit of prone depending on the situation. And then we started to understand two things. The first one is that prone positioning is a remarkable recruiting maneuver. Obviously, you know that I have been investigating recruiting maneuvers for a long time. And I was always trying to achieve the highest possible recruitment with the minimum amount of side effects. This is always in our mind. And now that we got this combination of prone positioning with EIT, we realized that prone positioning is a remarkable recruiting maneuver because think about this. You have the thorax, and then all this dorsal part of the thorax is where atelectasis predominates. And then to apply enough pressure to open this bottom part of the lung is very difficult to achieve enough pressure to open this area. But if I turn the patient upside down, now I have the atelectatic tissue here on the top. And then even applying a very low inspiratory pressure, I can reopen this region because the pleural pressures are more negative here, and then I can reopen much better. And then it has been very interesting that prone position is key. Just to give you an idea, we are now applying prone position not only because of a low PF, but whenever I see that I have too much atelectasis in the dorsal region, I prefer to turn this patient upside down and then applying a gentle level of PIP when doing this supine position again, and then I can keep the lung open. So I would say that I'm coming to the point that I'm applying prone position in almost all the patients.
Thank you, sir. Let me read through the chat box now. From Enggar Inam Saputra, so I'm guessing from Indonesia or Malaysia. Thanks, sir. Please give us more information on the flexibility of the lungs and resistance of the airway.
In COVID patients, I have seen very few problems with airway resistance. So I typically I don't see any problem with airway resistance in COVID patients. Typically, when I measure airway resistance, they are at very low levels. But I have seen lots of problems with secretions. And I now understood why. Because, you know, doesn't fit with the physiopathology of the disease to have too much secretions, because COVID, you have alveolar edema, but COVID is not a disease of the airways. So I was not understanding it, but then I realized why. These patients have a very high dead space. The minute ventilation is very high, and physicians and all the ICU staff, they love to use HMA, heated moisture exchanger, the filter. And these devices, they do not work when minute ventilation is high. So we should keep this in mind, that any heated moisture exchanger doesn't work when your minute ventilation is approaching 10 liters per minute. And all the COVID patients, they have 15 liters per minute of minute ventilation. So then we have terrible humidification, and then we have lots of problems with secretions. So in our hospital, we started to change the policy, and we try to use much more heated humidifiers, so active humidification.
Thank you, doctor. We have another question from When You Want Sim. Bertoni et al. Described using the POCC maneuver to calculate the predicted dynamic transpulmonary driving pressure. Is that a reasonable target for lung protection in patients undergoing assisted ventilation?
This is a very good question. Yes, it is a very, very reasonable. In my mind, in an ideal world, I would prefer to use transpulmonary driving pressure instead of driving pressure, right? Because I would like to understand let's say, the stress applied on the lung and not to the respiratory system, because the chest wall doesn't matter in this regard in terms of lung inflammation. However, let's say, for two practical reasons, I prefer to use driving pressure. Two practical reasons. First is that esophageal balloons are still very scarce, and then it's very difficult for us to measure transpulmonary pressures all the time, and then we don't have a clinical input and studies on safe limits of transpulmonary driving pressure. So we have much more information about driving pressure. And the second practical reason is that the chest wall compliance, especially in COVID patients, is typically normal. So then it's a predictable behavior, and then we don't have, let's say, whenever we have a very high driving pressure, it's because the lung is suffering, not the chest wall. And then, so for these two reasons, I have not used too much the transpulmonary driving pressure.
Just a follow-up question on that, Doctor. Again, from you, Wansin. The second question related to the earlier posted question is that what level is safe, perhaps pertaining to the transpulmonary driving pressure?
Yeah, I can tell you that very likely you should be a little bit more restrictive in the first. It's when the patient, you should be much more restrictive when the patient is inflamed. And then when the patient does not have inflammation, you can be a little bit more, let's say, relaxed. However, in COVID patients, they have peaks of inflammation, and you can track this by using biomarkers like C-reactive protein or lactic dehydrogenase or fibrinogen. And we can see that some patients, they have sustained peaks of inflammation. And then it's now well known that these patients have sustained alterations in permeability, which means that in some patients, even if it's already 2 or 3 weeks away ahead, but for one day, if the patient has a higher driving pressure, the next day the X-ray is completely white. So you have big lung edema again. So in general, we try to be more restrictive in the very acute phase, but you have to keep in mind that some patients, they have repeated peaks of inflammation. And then in these patients, you have to keep, let's say, boundaries of driving pressure during the whole stay. In general, I keep the total driving pressure below 15 and the transpulmonary driving pressure below 12.
Thank you so much, Doctor, for answering that question. We have another question from Indonesia. For COVID patients, could you share what is the recommended driving pressure value? Thank you.
I'm very happy when it's around 12, excited when it's 10, concerned when it's 15, and very concerned when it's around 20. So I try to be happy. I like to be around 12, 13. When I see a patient approaching 15, I'm already very concerned. And
okay, sir.
And remember that, for instance, it's interesting because it's in some patients, like a patient I was taking care yesterday, the patient has a very nice compliance, 50 of compliance. So when the patient has 50 of compliance, you can, let's say, if you're applying, let's say, 9 mLs per kilogram, the driving pressure is still 9-10 centimeters of water, which I consider very safe. So I don't care too much about the tidal volume, but I pay a lot of attention in the driving pressure. And when the patient has a very good compliance, it's very relaxing, because these patients, typically you can keep, when you relax on tidal volume, it's very easy to keep a good synchrony and to keep the patient very comfortable at the bedside.
Thank you, Doctor. We have a direct question. May I call on Mr. Dwayne Sell to ask the question directly? Thank you.
Dr. Amato, you and I have chatted about this in the past from time to time, and some of the doctors that have used the recruitability assessment that you presented as part of your lecture have the question as to, okay, if compliance, if you don't see the improvement in compliance, it's a pretty clear signal that there's not going to be a lot of benefit from doing a recruitment maneuver, titration, et cetera. But what degree of improvement in compliance or volume in that assessment would guide your decision as to whether it's worth the effort to do the full recruitment maneuver and titration?
So, Dwayne, I'm glad that we don't have many recent trips in the last years, because you have always asked me very difficult questions. But it's just, I'm just kidding. But this is a very difficult question, and one of the reasons is because this is giving me a hard time thinking about this. Okay, there must be certainly, if it's 0, it's a disaster. But how much is worth it? Gives you an information that it's worth it. I have the feeling, more or less, that just to give some example, I have seen patients with 50% improvement and some few patients with 100%. When it's 100%, I don't have any doubt, because you have more or less to imagine that you are doubling, you are making your lung size twice. But increasing at least by 50% your lung size, for me, it's a good signal. And then above 50%, I'm 100% sure. In between 25 and 50%, I think I would think about let's say, the whole clinical picture. And then below 25%, I very rarely I would suggest a recruitment maneuver, except if the patient has severe hypoxemia. If the patient is dying because of hypoxemia, then any recruitability means can represent an improvement in oxygenation. But if the oxygenation is reasonable, then I use more or less these numbers, okay? But you have to take into account the clinical context. Very good question, Dwayne.
Thank you, Doctor. We welcome any more questions from our participants. Please feel free to unmute yourself and ask the question directly, or otherwise you may also type them in the chat box. Just another question, Doctor. Somebody and sent the question to me directly. Since there are certain comorbidities that affect or put patients at risk, what is the difference of managing COPD patients with COVID with no complication? Thank you.
Yeah, difficult question and good one. obviously, we have seen some patients with COPD and COVID, and typically it's a very difficult patient to manage because these patients, they have already a big problem in the lung architecture, and then typically they have very easily overdistended. So in these patients, typically these are the most difficult patients to handle, because any wrong strategy causes a lot of overdistension. And on the other hand, if you don't apply a proper PEEP level, they typically have a very low oxygenation because they have already a previous lung disease and they have a problem with VQ matching. And then these patients, they are really a challenge. And these are the ones that we have to optimize the most. Certainly in these cases, I prefer much more to have a good monitoring, and I like to have EIT to manage. These are very difficult patients.
Thank you, sir. Another question. For a patient whom you're weaning off the ventilator on minimal PSB settings, how do you manage this patient if his driving pressures are high?
Please, can you ask me again?
Okay, sure. For a patient whom you're weaning off the ventilator on minimal PSB settings, how do you manage this patient if his driving pressures are high?
This is a very difficult question because, okay, if the patient is already weaning, you would like to go as fast as possible to the total weaning, because you are always afraid about nosocomial pneumonia in these patients. And I bet all the physicians, they have experienced it. You must have experienced this. These patients with COVID, they have lots of secondary infections because of this long stay, because of the use of steroids, and because of some intrinsic drop in the lymphocytes that they have. I have had lots of problems with fungus disease, with bacteria. So we would like to wean these patients as soon as possible. On the other hand, if the patient is very much inflamed, like I said, when you still have a high C-reactive protein, high levels of LDL, lactic dehydrogenase, and signals of fever, any, let's say, excess of driving pressure is going to cause lung edema for the next days, and then you are in a step back. So it's very difficult. So what I have done a lot is that I have used much more propofol than ever before, and propofol is a very good agent, because if the patient is now having a high driving pressure, I just use a little bit of propofol. I try to control the fever. I try to control the medications in the end, let's say nutrition, fever, general condition of the patient. And then next morning, or as soon as possible, I try to decrease propofol again without any side effects. So propofol is a very good drug to titrate the effort. And secondly, I try to follow these general rules in which I try to control the pH, I try to control the oxygenation, to never have some acidemia in the blood, or not having too much hypoxemia to enhance your inspiratory drive. And finally, in some patients, and I have used a lot, I give a little bit of propofol and a little bit of partial paralysis, because if I have a good monitoring of the brain, and I know that this patient is not conscious, so I typically like to use these brain monitors at the bedside that indirectly are measuring the electrical activity of the brain. And then I use a little bit of propofol and a little bit of paralysis, enough to decrease the strength of the inspiratory muscles. It's quite a challenge. We are developing some tools to titrate in the best way this dose, but it's really difficult. I hope in the future, this is my dream, we are going to have some magnetic devices that are going to interfere with the phrenic activity. And this is going to help us to modulate the level of patient effort. But for nowadays, we still have to use some drugs, and besides the general clinical management.
Okay. Thank you, sir, for answering that question. We have another question. Any advice if patient has developed pneumothorax? How will we manage in terms of driving pressure? Thank you.
Oh, yes. And pneumothorax in these patients is very common. I have seen lots of pneumothorax in patients during spontaneous ventilation, under CPAP or under pressure support, under spontaneous breathing. It's amazing. And for me, this is a typical example that because pneumothorax in these patients typically is a manifestation of patient self-inflicted lung injury. And it's interesting that most cases of pneumothorax were not were not caused during controlled mechanical ventilation. They happen during assisted or spontaneous ventilation. So they are related to this total driving pressure. And okay, if it's just pneumomediastinum, if you have only pneumomediastinum, which is very common, I treat the patient in the same way. So I try to minimize the total driving pressure. But if the patient has a pneumothorax and has some active air leak that is causing problems even with some chest tube, and then I have an active air leak that even using suctioning and negative pressure to suctioning the pneumothorax, you're still having problems, then you have to use a little bit different strategy, because the air leak, on one hand, is good because it promotes a good CO2 exchange. So CO2 is not a problem, but oxygenation can be a big problem, because if you have a pneumothorax and your lung is not occupying the internal cavity of the thorax, you have a big problem in oxygen. You may have a big problem in oxygenation, and then you have to minimize your air leak. And then when you have air leak, active one, so the general principle is that the leak is proportional to the square of your peak pressure. In fact, the square of the difference between peak pressure and pleural pressure. So two general principles. You have to decrease your peak pressure, not only the driving pressure, but you have to decrease your peak pressure. So, which means that you have to promote more muscle pressure and less ventilator pressure. And secondly, you try to put the position of the leak in the dependent position. So you typically try to put, for instance, the lung that is leaking in the dependent position by using lateral decubitus or prone position.
Thank you so much, Doctor. Another question is being asked, if I may read, Doctor. For lung recruitment maneuvers, do you have any preferences or suggestion?
For lung recruitment maneuvers, I I think my preference today is to use pressure control ventilation. I like to do automatic recruiting maneuvers with the ventilator because I believe it's safer than doing manually. So many ventilators now, they have this possibility. I strongly advise you to test because it increases safety a lot because you can pay attention to the side effects of the maneuver, and then the automation avoids many mistakes that we do at the bedside. And you set your boundaries in pressure control to not exceed a certain amount of pressure. And just to give you some numbers, practical rules, in our protocol, we have applied in more than 100 patients, and we didn't have a single case of pneumothorax. So in general, our maximum inspiratory pressure is set to 45, and if the patient is obese and has a very high body mass index, we go up to 50. But we try to keep in most patients up to 45 pressure control ventilation, maximum of 30 seconds or 1 minute at this highest pressure. And typically we use a staircase maneuver, going up and going down under pressure control ventilation.
Thank you very much, Doctor. Perhaps we can accommodate 2 or 3 more questions. And anybody from the participants, you may unmute yourself and ask the questions directly. Thank you very much. Okay, we have another question, Doctor. What can we do with mechanical ventilation in COVID patients when pulmonary edema comes into the picture and when pulmonary embolism comes into the picture?
Oh, pulmonary embolism is a challenge for these patients because there is a complete dissociation between your blood gas and what is going on in terms of lung protection and what is going on in terms of lung collapse. But in general, I try to apply the same principles. I try to put priority on lung protection and not on blood gas. In these patients, when I have a high suspicion of pulmonary emboli, and I try to use nitric oxide because then I keep the mechanical ventilation based on protective lung strategies, and then try to control the hypoxemia with nitric oxide. And this has been my general approach.
Thank you, sir. Any more questions from our audience? Okay, let me just run through the chat box once more. Okay, so there being none, I just wanted to thank again Dr. Amato, and I would like to ask the audience as well to send their regards to Dr. Amato. And as part of the new normal, as we say it, we always end with the photo opportunity, screen grab to include our participants and the speaker. So it's now a new trend, a new normal in this post-COVID era. So may I invite everyone to please open up their cameras. So for a photo opportunity with Dr. Amato, thank you very much.
Hi to everyone.
Okay, so we'll just do a quick photo opportunity with Dr. Amato before we finally present the certificate of appreciation to Dr. Amato. So may I invite everyone to please open up their cameras. Okay, On cue, 1, 2, 3, go. Okay. One more. On cue, 1, 2, 3. Last one. So I have 3 panels.
My big pleasure to be around.
Thank you very much, everyone, for joining this event, and we look forward in your participation in other programs and activities we have. But again, we would like to reiterate the invitation from the Asia Pacific Intensive Care Society with the APICS 2021 happening on 17 to 19 July 2021. So before we end this session, we would like to present the Certificate of Appreciation to Professor Marcelo Amato as our research speaker with the topic, what COVID patients have taught us about lung protective strategies. Should we tighten or relax lung protection? Presented this 20th of February 2021. Thank you very much, Dr. Amato.
My pleasure.
So we hope to see you again.
Happy Saturday to everyone.
Thank you so much. Thank you so much for spending your weekend with us. And God bless, keep safe, and we'll see you all in the
Thank
future.
you.
Thank you.
Hi, Josh.
Thank you so much, Dr. Marcelo Amato.
Ay kahit na sir, may trabaho naman siya. Hindi naman walang pera. Hindi pera yung inspeksyon. Basta may problema siya. Maliban din sa